So thank you, Dr. Bond. I think this has been an absolutely superb meeting with some world-class speakers. We've had recurring themes, and it's a real challenge to do justice to the super speakers that have given us their major insights today. But over the next 20 minutes, I will try and attempt to discuss what the major strategies, in my view, are to address sex disparities across the cardiovascular continuum and age spectrum. So if I may ask you to move on to the next slide. So let me just, in terms of what we do, the talk's going to cover 6 main focus areas. First and foremost, the best way to prevent disparities is to prevent cardiovascular disease occurring in the first place. And really, I'm going to discuss public health measures that can target inequalities in socioeconomic status and education, which I believe would impact on women's cardiovascular health. Secondly, I'm going to cover research programs, particularly to study inequalities in women's cardiovascular health. We can't impact on something that we don't know exists. Thirdly, sex-specific evidence synthesis. I think we've seen in many of the talks today, diversity in research and leadership, and that's a real important point to address. Fourthly, sex-specific guidelines, and in particular, improving sex-specific reporting. We can't make guidelines unless we know that the treatments that guidelines suggest are efficacious in women. Fifth, I think what we've seen today is meetings such as these are truly superb. They highlight inequalities, they highlight disparities, and they highlight the magnitude of problems that we face as a community in women's cardiovascular health. And finally, sixth, allyship, and why engaging all members of society is important. Disparities in women's cardiovascular health is not a problem for women. It's not a problem for 50% of the population. This is a problem for each and every one of us. I don't want to be part of a healthcare system that my mother or my daughter have worse outcomes. This is important. It's important for every single one of the people in the audience. Next slide, please. So we know that mortality in cardiovascular disease with socioeconomic status go hand in hand. This is data from the PURE study from Salim Yusuf. And what it shows is worse cardiovascular outcomes associated with poor socioeconomic status, irrespective of whether individuals live in high or low income countries. Next slide, please. This is data from the United Kingdom. This is data over 15 years, and it shows mortality associated with socioeconomic inequalities. You can see a significant excess mortality in patients that are most deprived, close to 300,000 excess deaths in the most deprived patients over a 15-year period. The right-hand panel illustrates the years of lives lost associated with socioeconomic inequalities, and you can see in the most deprived patients, you have 6 years on average of life lost before the age of 75 by virtue of their socioeconomic inequality. Next slide, please. Again, this is same data from the UK. Next, please. So you can see the column mortality attributed to socioeconomic inequality. Next, please. You can see that cardiovascular disease is associated with significant mortality associated with socioeconomic inequality. Up to 40 to 50% of cardiovascular deaths are due to socioeconomic inequalities. Next, please. And again, and this is years of life lost to inequality. And again, you can see that across all different cardiovascular conditions, we have significant years of life lost to inequality. Next slide, please. So, are there inequalities in premature mortality rates between sexes? Again, this is data from the United Kingdom. And you can see that in females. Next, please. In the most deprived, over a period of 15 years, the slowest rate of change has been amongst women. We're not doing a good job in reducing the relationship between deprivation and sex. Next, please. So this slide illustrates sex-related differences in socioeconomic status, education, and cardiovascular disease. Next, please. And what we see here is that socioeconomic conditions can impact on women, both at the very early stage, in the early stages of life, so intrauterine conditions such as birth, leading to low birth weight, development of atherosclerosis, can impact through educational and environmental factors. So, for example, in childhood, relating to childhood obesity, smoking, exercise, development of atherosclerosis. In poor working conditions, so for example, impacting on adulthood through job stress, job insecurity, again promoting cardiovascular disease, and finally through income and assets through older age, resulting particularly in healthcare systems such as in the United States, inadequate medical care and reduced function. Next slide, please. So socioeconomic interventions are important, and they're important of cardiovascular health, where particularly women do not have educational opportunities compared to men. And the biggest intervention has consistently been shown in reducing these disparities would be public health measures targeting inequalities in socioeconomic status and education in women. Next slide, please. I think really one of the major points that's come through the presentation today is to discuss, to understand inequalities in women's cardiovascular health, we need to study them. Next slide, please. So this is some of the work that my group has undertaken. We know that women have significant and defined risk factors for cardiovascular disease, and particularly women-specific risk factors. This is some of the work that my group has published, led by Ponce Wu. Looking at preeclampsia and future cardiovascular health, we know that women with preeclampsia have marked increased risk of future cardiovascular events. Next slide, please. This evidence synthesis can also look at the evidence and the treatments that we give women. This is data looking at management of non-ST elevation myocardial infarction derived from the United States, again published by my group. And you can see, next slide, please, that women are 10% less likely to be referred for cardiac catheterization. So these sorts of studies are important in highlighting disparities. Next, please. But it's not only that women are less likely to be offered cardiac catheterization. The timing of cardiac catheterization is often delayed in women. This is data from the United Kingdom in a universal healthcare system where you would think there would be no disparities. But this data again suggests that there are quite significant disparities. Next slide, please. What it shows is that high-risk women are 10% less likely to receive invasive coronary strategy within guidelines. And furthermore, it shows that low-risk men are twice as likely to get an early cath compared to high-risk women. And this is in a universal healthcare system. So again, having data such as these is important. Encouraging this sort of work, outcomes-based research, is important. You can't address disparities unless you can measure them. Next slide, please. I think also it's important for journals to focus research efforts and raising profile of women's cardiovascular health. We know that Circulation has a Go Red for Women section each year around February, where it publishes work around disparities in women's cardiovascular health. Next slide, please. But this shouldn't be a focus once a year. This should be something that's on our mind all the time. This is something that affects half the population. It's not for February every year. This is a problem that we face on a daily basis. This should be a priority for journals to publish and report upon. Next slide, please. I think the other area where we can reduce disparities is research into women-predominant cardiovascular conditions. For example, spontaneous coronary artery dissection. Dr. Sharon Hayes, who's present at the symposium, has really highlighted a lot of the work in spontaneous coronary artery dissection with publications from over a decade, and Jackie Saw as well. Similar has had great impact on the field. This is important. One of the most memorable cases I undertook as a fellow, as an interventional cardiology fellow was in a lady with spontaneous coronary artery dissection, where we stented and we toothpasted the lesion and we carried on stenting. This was at a time I'd never heard of coronary artery dissection. We showed it to my attendings, who again were puzzled by this. It's only through the efforts of people like Sharon Hayes and Dr. Jackie Saw that now, when we see such cases, SCAD immediately appears in mind. So I think it shows a key role for promoting research into women-predominant cardiovascular conditions. Next, please. And this promotes guideline recommendations, as we see here. Next slide, please. I think one of the key factors around deciding what the research agenda should be is research leadership, and we see quite significant gender disparity in first authorship of cardiology randomized controlled trials. This is a research letter by Anka Kalra, Oksana Miran, and some of the other people that we know, showing that women are grossly underrepresented in the leadership of randomized controlled trials. Next slide, please. And even in cases where there's joint first author, next slide, please, you can see that females, when there's a joint first author, females are far less likely to be the first author compared to males, even though it's felt that by giving them joint first authorship, the impact and the role of the individuals is equal. Men are consistently more likely to get that first role, which I think is inappropriate. Next slide, please. And promotion, we know that there is a leaky pathway, and even for women that do make it penultimately and stay in academic medicine, we know that there are major differences in promotion to either associate professor or to full professor. This has to change. If it doesn't change, we will continue to see major disparities in women's cardiovascular health. Next, please. I think key is increasing representation of women in cardiovascular trials. How can we advocate efficacy of treatments when we don't know whether they work in women? This is a case in point. This is one of the landmark PCI trials looking at drug-eluting versus bare metal stent in women and men with prior coronary artery bypass grafting. Next, please. And this was run by the DEIB investigators. So with such a name, you would expect that there would be a lot of women recruited. You would expect P for interaction being presented, showing efficacy for effects on women versus men. Next, please. In here we have, next, please. You can see that in this whole landmark trial of bare metal versus drug-eluting stents published in the Lancet, a sum total of 2 women were recruited. This is unacceptable. Next slide, please. We also see consistently that women are far less likely to be recruited into randomized controlled trial than men. You can see that in this study led by my research collaborator, Dr. Harriet Van Spoor, only a quarter of women were represented in randomized controlled trials in patients with heart failure, and 70% of trials under-enrolled females relative to the disease distribution, with 40% of randomized controlled trials recruiting less than 20% of women. We have to do better than this if we're ever going to think about reducing sex disparities. Next, please. Why is it important around trial leadership that we talked about earlier? Well, one of the most important independent factors for reducing the under-enrollment of women is leadership of trials by women. Women have a lower odds of under-enrolling women into their trials. Next slide, please. This is an important piece of work by Dr. Mikos and by Dr. Van Spoor, and you can see that they offer several solutions for increasing representation and diversity in clinical trial populations. For example, increasing diversity amongst frontline research staff, implementing recruitment processes to increase diverse enrollment, the role of funding agencies. For example, the way to increase diversity in trials is by increasing diversity in leadership. peer review, having diverse peer reviewers to increase award of grants to women. I think it's important for journals to have certain standards, and the standards include sex reporting, and making sure that the recruitment of patients relates to the ratio of trial participants to disease prevalence. And I think there are clear benefits of enrolment of proportionate to disease distributions. For example, Dr. Ferdinand gave a great discussion around generalizability of trial, assessed for subgroup interactions, and also making sure that the treatments that we offer women are efficacious. Next slide, please. And I think there's certainly an important role for societies. This was a position statement by Dr. Mikos and Dr. Ferdinand, and again, showing that it's important to have societal statements about highlighting the importance of enrolment of women into randomized trials and how we can achieve this. Next, please. I think guidelines are important, and I think Steve Jobs is a hero of mine, and I very much agree with his sentiments. Ideas are worth nothing unless you can execute them, and that's very much the same applies to guidelines. I think guidelines are worthless unless they can be executed, and can be executed within a population without disparity, and that's something that we don't see. Next slide, please. I think guidelines have improved. This is from the current ACC, American Heart Association chest pain guidelines. And what these show is that they do have certain sections, particularly around uniqueness of chest pain in women. And I think it's important for guidelines to think about sex, and particularly their recommendations. Next slide, please. These are the ESC guidelines. And again, I think it's important for guidelines to present conditions and cardiovascular diseases that predominantly affect women, such as MINOCA, such as SCAD, and produce recommendations around these. Next slide, please. The problem with guidelines is that they rarely propose sex-specific recommendations or quote sex-specific levels of evidence unless the diagnosis is specific to women, such as SCAD or MINOCA. I think the relationship between risk factor and cardiovascular outcomes are very different between men and women, and it's not considered in recommendations. And the response to treatment is very different by sex for a number of things, such as digoxin in heart failure or Entresto in heart failure, for example. It's often not considered in trials, and they don't report sex-specific interactions for outcomes. And so how can our guidelines advocate for differences in treatment between men and women when we don't have the data? Next slide, please. And this is one of the problems of guidelines. I was one of the review coordinators for the ESC 2020 guidelines, and literally there is one paragraph around sex disparities. And furthermore, we talk about disparities, but there's very little guidelines about how we action or address these disparities. And I think that's important. Next slide, please. When we look at the literature as to why we have very few sex-specific recommendations, I think it comes from the randomized controlled trials. Very few of the randomized controlled trials look for sex-specific outcomes or report sex-specific interactions. This is a table from one of Dr. Harriet Van Spaal's papers looking at sex differences in heart failure management, risk factors and outcomes. And you can see that the vast majority of landmark heart failure trials do not report sex-specific outcomes. If that's the case, how can this be used? How can this data be used to inform evidence and guidelines? It can't. Next slide, please. I think there is a role for sex-specific guidelines. I think one has to think about, when you're developing sex-specific guidelines, are there sex-related differences in risk factors or pathophysiology that may influence the disease, such as disorders of pregnancy, premature menopause, inflammatory conditions? If there are, we should think about assessing for sex-related differences that may have implications in the treatment of disease, and also assess whether there's a difference in the body of evidence for sex-specific evidence. Unfortunately, there isn't for many of the cases, because randomized controlled trials do not report sex-specific differences in interactions. I think if all of these conditions are met, then I think there is certainly a role for sex-specific guidelines, prevention and treatment recommendations. And one needs to make this a dynamic process, very much like audit. You have to circle and close the loop, in that you always have to assess upcoming evidence and see whether there is requirements for sex-specific guidelines for cardiovascular disease. There may not be now, but there may be in the future as the evidence evolves. Next, please. I think one of the key factors and one of the key roles of societies is to advocate for underrepresented groups, particularly around race. But I think societies also have a very important role in advocating for women. There are a number of fantastic societal position statements. So, for example, that of the ABC group, particularly around the working the agenda for Black mothers. I think the role of these is to encourage debate, highlight the disparities, but importantly, provide actionable solution, a call to arms for the cardiovascular community to get behind. Next slide, please. We also have important roles within our society, such as the American Heart Association and ACC. They have women in cardiology groups. These are very important. They highlight disparities in women's cardiovascular health. They are an important cause of call to arms. They advocate for women and they support women in their careers, particularly when we see leaky pipelines. And when I've shown you earlier data of the reduced chance of women being promoted from an academic perspective, these sorts of societal leaderships have a very important role. Next slide, please. Last 2 minutes. I think allyship is important. There is a role for men in all of these committees and endeavours. This is not a problem of 50% of the population. This is a problem for all of us. Final slide. And this is a great paper. If you have a chance to read it, then I would thoroughly recommend that you do so. It gives the key messages around how to shorten cardiovascular disparities in women and actions that can be undertaken. Very last slide. And these are the final points. The ways to reduce disparities are reduce development of cardiovascular disease in the first place through socioeconomic interventions, encourage the study and reporting of sex-specific disparities, ensure diversity in research and leadership, improve sex-specific reporting in trials that will impact on guidelines, meetings, and make men allies. Thank you.